Welcome back to the next Appraisal Tool modules. In this module, we'll be discussing question 16, are the statistical analyses clearly described? When answering this question, look for the Methods section, and often articles will have a separate section labeled Data Analyses. First, let's talk about data and variables. Variables represent anything that has a quantity or quality, and they're called variables because they vary. They're expected to differ in the amount or type. An independent variable is expected to cause a change in the value of an outcome. This is typically manipulated by the researcher. And then we have the dependent variable that is expected to change. Data are the values of each of these variables. Data analysis is just the organization and testing of information to answer a research question. As you read an article, the author might also mention confounding variables. Confounding variables are factors that may influence both the independent or dependent variable. The presence of these factors introduces alternative explanations for the change in the dependent variable and therefore would reduce the validity of the study results. In other words, the researcher might find a relationship between the independent and dependent variable that does not exist because the confounding variable caused the change in the dependent variable. This figure illustrates a randomized controlled trial designed to test the efficacy of a multi-level intervention to improve low-income maternal smokers' abstinence and reduce child tobacco smoke exposure. The multimodal behavioral intervention in the yellow oval is the independent variable. It is expected to cause a change in the dependent variables in the blue oval, smokers' abstinence and child tobacco smoke exposure. The orange oval shows us 4 important participant characteristics that could affect the intervention or the dependent variable and thus distort the true effect of the independent variable on the dependent variable. The investigators controlled for these potential confounding factors by including them in their regression analysis, and thereby this control increased the validity of the study results. As a clinician, you need a general understanding about the data collected and the statistical tests used to examine these data. There are 4 levels of measurement used to assign numbers to information collected and determines the type of statistics we can use. They are ranked from the lowest to the highest level of data, or the least amount of information to the most precise amount of information. Nominal is the lowest, ratio is the highest. We can use more advanced statistics with the more precise data, the ratio. Nominal refers to categories of information, such as whether a patient has a specific diagnosis. Ordinal categories are just that. They're ranked in the order of amount, but the difference between each category is not exact. Interval categories are a higher level of measurement because these categories have equal distance between them. We know the exact difference between a Fahrenheit temperature of 100 and 101. Ratio data is the highest level of measurement, again because it's the most precise. Rather than simply knowing whether someone is pre-diabetic or diabetic, we have a precise value of their serum glucose. Descriptive statistics summarize information and are used to describe characteristics of study samples and other key study variables, such as outcomes. The count is the number of times a value occurs. A frequency table will typically report the count and the percentage that each value occurs. The center of the data is described using the mean, also known as the average, the median, also known as the number that falls in the middle when numbers are sorted from smallest to largest, and the mode, the number that occurs most often. These values tell you about the center of the data. The figure on the left shows that in a normal distribution, a bell-shaped curve, the mean, median, and mode fall in the center. The figure on the right shows a distribution with the mean being pulled to the left of the median by extreme values. We call this skewed to the left. When the mean is pulled to the right of the median, the distribution is skewed to the right. It's best to use the mean when the distribution is fairly symmetrical, like the bell curve, and there are no outliers. The mean is highly sensitive or influenced by extreme values in the data. It's best to use the median when the distribution is either skewed or outliers are present. In this case, the median will represent the typical value. For example, when we're looking at gestational age, the majority of infants are born late in the third trimester, closer to 40 weeks, so the top of the curve will be to the right of the distribution, and there'll be a long tail to the left that accounts for the extremely premature infants. In contrast, when you look at the distribution of income in the United States, the majority of household incomes will be under the top of the curve on the left of the chart, and there will be a long tail to the right, illustrating those with the highest incomes. The mode is often used when describing categorical data. For example, which day of the week most community members come to a community clinic for a vaccine. Variation or spread of the data is described using a range, standard deviation, and variance. The standard deviation is just the average distance of the values from the mean value. The variance is the standard deviation squared. You will not need to calculate these. Just know the larger the spread of the data, the larger each of these statistics. There are many statistical tests that require a normal distribution to produce valid results. Authors typically report if the data were not normally distributed and which statistical test they chose to ensure the results are valid. In statistical testing, there's a null hypothesis and an alternative hypothesis. The null assumes there is no relationship, that the intervention is not effective. We assume the null is true, and the statistical tests are conducted to determine if we can reject the null hypothesis. We can never know with absolute certainty whether results are accurate. There's always a possibility of making an error. A type 1 error is consistent with a false positive test. We reject the null hypothesis, but there really is a relationship. A type 2 error is consistent with a false negative. The researcher reports there is no relationship, but there is. In an article, the author will also report the alpha. This indicates the probability of making a type 1 error. Researchers commonly set the alpha at 0.05. This means there's a 5% risk the test results are the result of a type 1 error. Related to the p-value is a confidence interval. If the significance level is 0.05, the corresponding confidence level is 95%. This is simply the range of likely values for a population parameter, such as a population mean. A 95% confidence level means that there's a 5% chance that the test results are the result of a type 1 error. To determine statistical significance, we look at the p-value, or the confidence interval, of the observed data. A p falls between 0 and 1. If the p-value is less than the significance level, the alpha, or the confidence interval does not contain the null hypothesis, a 0, the results are statistically significant. In general, the smaller the p and the more narrow the confidence interval, the more confidence we have to reject the null hypothesis. Power is the probability of not making a type 2 error. High power is good. During planning, power is calculated and also takes into account the effect size. This refers to the estimated size of the difference between the groups or the change in the dependent variable. The larger the effect size, the higher the power. A power of 80% means the author has an 80% chance of not making a type 2 error. If the purpose of the study is simply to describe a phenomenon such as the prevalence of disease, then there's no hypothesis and no statistical testing. The author will use descriptive statistics such as means and percentages to describe the information collected. Researchers use inferential statistics shown in this table to test study hypotheses. Inferential statistics use the values in the sample to estimate the values in the larger population. So when testing a hypothesis, we have to also consider the measurement level. Looking at the test for differences between groups, a very common test is the chi-square that compares differences in proportions. A t-test will examine a difference in a mean between two independent groups. An ANOVA is an extension of the t-test in that it allows the comparison of mean differences between two or more groups. The ANCOVA differs from the ANOVA in that it controls for potentially confounding variables that might lead to inaccurate results. Associations between two variables can be tested using the Pearson's R. This identifies the strength and direction of a relationship between two continuous variables. It can only examine an association and cannot determine if one variable causes a change in the other variable. Relationships among two or more variables can be tested using regression and other types of modeling to predict outcomes. Logistic regression uses a dependent variable that has two categories, such as yes or no, whether my patient has hypertension or not. Linear regression uses a continuous dependent variable, such as depression score or birth weight. As mentioned earlier, the distribution of data helps determine statistical test. When data fall into a normal distribution, parametric statistics are used. When the distribution is not normal, it uses non-parametric tests. Examples of non-parametric tests include the Mann-Whitney, Kruskal-Wallis, and Friedman. Clinical trials might analyze the risk of an outcome. This tells us about the size of the effect of an intervention or exposure. Risk typically refers to the probability of an adverse outcome, but it can also tell us about the risk of a favorable outcome. Absolute risk is expressed as the percentage of the total number of people in each study group. It is the percentage of people who have the outcome in a study group. Absolute risk reduction is when the risk of an adverse outcome is lower for the intervention group than the control. For example, if the absolute risk reduction of receiving a new treatment to reduce breast cancer is 8%, then 8 out of 100 people would benefit from the intervention. Relative risk compares the risk between study groups and estimates the effect size of the treatment. If relative risk equals 1, there's no change. If relative risk is less than 1, then the intervention lowered the risk of the outcome. If relative risk is greater than 1, the higher the risk of the outcome. One more way to understand risk is looking at the odds ratio. It's the odds of the outcome occurring in the intervention group divided by the odds of the outcome occurring in the control group. Consistent with interpreting relative risk, if the odds ratio is less than 1, there's a lower risk. If it's equal to 1, there's no difference, and if it's greater than 1, there's a higher risk. Authors should clearly describe how each of these is calculated. Here are 2 additional results that tell us about the likelihood of an outcome when exposed to an intervention. Number needed to treat is the number of individuals who need to be treated to prevent one adverse outcome. If the number needed to treat is 5, that means that every 1 in 5 individuals will benefit from the intervention. Number of needed to harm is the number of individuals who need to be treated for one individual to be harmed. That might mean it's negative side effects. If the number needed to harm is 65, for every 65 individuals receiving the treatment, one will be harmed. We want our interventions to have lower number needed to treat and higher numbers needed to harm. A methods section may also describe a power analysis. As mentioned earlier, power is the ability to reject the null hypothesis that there is no difference or that the treatment will not work. A description of the power analysis should contain the amount of power selected, and the standard is 80%. It should contain the alpha, the expected effect size, and the sample size. Authors will often predetermine their sample size based on the number of participants required to detect a difference between study groups or to detect a relationship between variables. It's easier to detect a statistical significance when the effect size is larger versus smaller and when we have a larger sample. Larger studies are also able to detect smaller effect sizes. Statistical significance is different than clinical significance. Clinical significance is the practical importance of the study results. They have meaningful impact on healthcare decisions and the health and well-being of our patients. For example, an exercise intervention for adults with BMIs greater than 30 that generates a 500-gram weight loss for the intervention group might reach statistical significance, but this small change may not be clinically meaningful. Will a 500-gram loss affect healthcare decisions about which medication to use or potentially reduce hypertension? That's what you have to think about when you look at statistical significance. Do these findings impact patient care? Let's look at some examples of published articles and their statistical analyses sections. These investigators conducted a randomized control trial to evaluate the efficacy of an interactive web-based sexual health program for developing sexual assertiveness skills and enhancing sexual decision-making in adolescent girls. They assessed participants at pre-test, immediate post-test, and 4-month follow-up. Looking at the narrative, we can see the description of their analysis is very clear. They walk the reader through each step, from first describing the sample, then examining attrition rates, or the percentage of participants who drop out, and then they assess the impact of the intervention on study outcomes in steps 3 and 4. Models that are adjusted or controlled take into account confounding variables. Remember, these are variables that influence the outcome or influence the intervention, and they need to be adjusted for. Because we want study groups to have similar characteristics, when there are 2 or more study groups, authors should indicate that they examined whether there were any differences in participant characteristics. Again, this is important for identifying variables that might be confounding the relationship between the independent and dependent variable. If there are differences, these variables should be included in the analysis. Attrition is important for understanding differences in sample sizes between the different study groups over time. If there's differential attrition, meaning one study group has a much larger dropout rate than the other, then we run the risk of the study groups becoming too different. We want study groups that are similar because that helps us detect whether or not an intervention caused a change in the dependent variable. It wasn't the characteristics that differed that caused a change in the dependent variable for one group or the other. These authors indicate the analyses were adjusted for baseline measures and school. The final model was a linear generalized estimation equation model. This is used when there's repeated measures, meaning the same measure is used more than once, typically at baseline prior to the exposure of the intervention, and then follow-up data collection points. In this study, the investigators' objective was to estimate breastfeeding initiation rate differences between African Americans and Black immigrants enrolled in the District of Columbia WIC program. They clearly described their analysis strategy, starting with bivariate analysis to examine the association between participant characteristics and the outcome, breastfeeding initiation. When a characteristic had a statistically significant association or was conceptually important based upon the review of the literature, the authors included the variable in the regression analysis as a covariate to control for or adjust for its influence on breastfeeding initiation. By including it in the regression model, they could separate out the influence of the covariate from the influence of race. The authors also report a p-value of 0.05 and a confidence interval of 95%. Both are standard values of significance. Authors list the hypothesis being tested and the use of a two-sided t-test to examine change over time. A two-tailed test is appropriate if you want to examine either an increase or a decrease. A one-tailed test is appropriate when you hypothesize the direction of the relationship. You hypothesize an increase or you hypothesize a decrease. Quantitative studies should report statistical power. This study examined parents' decision-making related to a vaccine. The most common reason to conduct a power analysis is to determine the required sample size to detect statistical significance. Components of a power analysis include significance level, expected effect size, and power selected. Some statistical programs also ask you to input the number of independent variables. Power is typically set at 80% or higher. In this study, authors report a significance level of less than 0.05. The effect sizes for the two dependent variables are 49% and 32%, and they report a type 2 error of 0.7. As shown in an earlier slide, we can calculate the power by subtracting the value of the type 2 error from 1. So the power in this study is 1 minus 0.07, which is only 30% power. If a study does not demonstrate statistically significant results, one possibility is they didn't have adequate power to detect relationships among the variables. If a study reports statistically significant results, then it had adequate power for the analysis. Here is a passage from a published article to help us answer the critical appraisal question, are the statistical analyses clearly described? You may wish to take a moment to pause the presentation, read over the passage to find the answer, and when you're ready, restart the video to see how I answered. In forming your appraisal response, decide if you think the authors clearly described data analysis. While you might not remember these exact tests, this author provides detailed information that would allow you to look them up and refresh your memory. If the author leaves you questioning how they handled the data, you would answer no. When reading the full article to place this section in context, you will notice this author lists data analysis for each outcome. We see that the author uses means and percentages to examine feasibility, acceptability, and satisfaction, and they reported that they tested the effect of the treatment on hopelessness and physical activity by using t-test and chi-squared. All of these tests are consistent with the study purpose and the type of data collected. Congratulations! You successfully completed this module. You may return to the main menu or continue to other appraisal modules in the next EBP course.